Good afternoon. So I'm Beth Miller. I'm a nurse practitioner student at Auburn University, and the purpose of this video is we're going to be completing a comprehensive physical assessment. Before we get started, I just want to say that throughout a normal comprehensive assessment, you would always be assessing the skin. So whenever you get to a specific system, whether it be the thorax, the abdomen, that kind of thing, you would always remove clothing. For the purposes of this exam, since it will be on YouTube for a little bit, we will maintain modesty at times and not remove clothing like you normally would, but just want to let that be known that that's what I normally do. Whenever you're assessing the skin, you're looking for the color, any obvious lesions, you're looking at the vascularity of the skin, the turgor, the temperature, anything like that, and you're looking at throughout the exam. Then, so to start with, I would also do hand hygiene before I get started for patient safety, and then I would just start by looking at the patient's general appearance. Is he in any acute distress? I would watch him as he walks in the room for his gait, his posture, that kind of thing. Also look at his, as we talk more, kind of assess his mood, listen to his speech. Is he talking appropriately? He's not slurring his words or anything like that. And then after that, we would assess vital signs, which would include the blood pressure, the heart rate, the temperature, the oxygen saturation, the respiratory rate, and then we would assess for pain. If he did have pain, we would talk more about that and assess the 7 different qualities of pain, or any symptom that we would assess. So from there, from the general appearance, we'll go on to the head. So we're going to start with inspecting the head. You're looking at the head, the scalp, and the skull. You're inspecting, is there obviously any deformities, any deviations, as far as indurations, masses, bulges, abnormalities, anything like that, any sign that he previously had any kind of trauma to that area, or any kind of surgery. After inspection, and also you're looking at the hair at this time, the distribution, is there any baldness noted, does it appear shiny, does it appear clean, and that's another part of the general appearance. You're looking at the patient's dress and their hygiene. So as you're looking, after you inspect, you're going to start palpation of the head and the hair and the skull. You're feeling for any indurations, masses, bulges. This is specifically important in pediatric patients as they have fontanelles. You would palpate those. Then you're palpating the hair for the texture, the distribution, that kind of thing. So after we move from the head, then we will move to the eyes. So for the purpose of this exam, I'm going to go through all the body systems, and then at the end we'll recrack cranial nerves that we had not hit. So for your eyes, first I'll do inspection. I'll just be looking at his eyebrows, the hair distribution on his eyebrows. Is there any flakiness, redness, that kind of thing? Then I'll be looking at the eyes themselves, the eyelids and the eyelashes. Is there any edema or redness, any discharge, any irritation obvious, any tearing noted? After inspection, we will begin palpation. So I will palpate his lower lid and better visualize the sclera, the cornea, the conjunctiva, iris, and the pupil, looking to see is there any obvious redness, anything abnormal as far as the cornea goes, is there any cloudiness, is this conjunctiva pink, that kind of thing. After inspection, with that, we will move on to the ophthalmoscope. So it's very important with the ophthalmoscope that you, as you look at the right eye, or when I look at his left eye, I use my right hand and vice versa. So, and use the eye that goes with the ophthalmoscope. So we'll start by turning it on. It'll start at 0 diopter. Then I would move it up and down to match his and my vision so that we can best visualize the anterior portion of the eye, the posterior portion of the eye. So we'll start by finding the light after the red reflex. In this case, it's turquoise, but it's normally red. You'll shine it. You'll look to see the back of the retina. You'll visualize the arteries and veins or the vessels as they go to a central point. Then to the lateral of that, you would have the macula and the fovea. Then you just look at the integrity of that. And you'll do this on both sides. Okay. After we complete the ophthalmoscope exam, then we're going to use the pen light to test his vision as well. Okay, so first to check your actual vision, we'll use what we call a Snellen chart. The purpose of this chart is to check his farsightedness. Since we don't have the distance to see all this in the camera, we'll talk. This would be 20 feet away. I would have him read on the line he could read best. Whatever that would be, the number beside it would indicate his visual acuity, so like 20/20, that kind of thing. So that would be 20 feet away, and we would find that. Then also to check his near field of vision, we would have a similar chart but on a smaller card to check that. So that would be visual acuity. So from there, we're going to use our pen light. I'm first going to let you do the uncover test. So the purpose of that is you're trying to check for any lateralization of one eye versus the other. So I'm going to let you cover your left eye. Uncover it. Cover your right eye. Uncover it. And I noted no deviation from that. So next we're going to do the static wiggle test. Finger wiggle test, which is just to check and see your field of vision. So I'm going to let you cover your left eye. I'm going to cover my right eye. I'm going to wiggle fingers, kind of like in the different hours of the clock, and I'm going to let you tell me when you see them and how many fingers I'm holding up.
1, 2, 3, 4, 1.
Okay, let's do it on the other side.
1, 2, 3, 4.
Perfect. Okay, so that will be the cover-uncover test. Next, we're going to look at the corneal light reflex, which is just where you shine the light and you look for the light in both of his eyes bilaterally. Then after that, we're going to look at perla, pupils equal, round, reactive to light and accommodation. I'm looking to see, does the pupil react to the light directly, and does the alternate eye retract like it should, and his do. Okay, I'm going to let you follow the pen with your eyes. Yes, and his did respond appropriately. Okay, after the eyes, we're going to go on to the ears. So to start with, we would listen for hearing. We're going to do that with the Weber and the Rhine test as well as the whisper test. We're going to start with the Weber test. So for that, I'm going to use a tuning fork. I'm going to strike it. Then I'm going to plant this on the top of your head, and I'm going to let you know if you hear it on both sides or just one side of your ears, okay?
Both.
Perfect. Okay, so that's lateralization. That will be the Weber test. Next, we'll do the Rhine test. And I'm going to put it on your bone back here, and I'll let you know, tell me when you stop hearing it.
Okay.
Let me know when you stop hearing it.
Okay.
And again, bone conduction was less than air conduction, which is appropriate. And we're going to do it again on the next side.
Okay. Okay.
Perfect. Okay, after that, we're going to complete the whisper test. So I'm going to stand behind you. I'm going to whisper something on each side of you and let you repeat after me. A, 2, B.
A, 2, B.
B, 3, D.
B, 3, D.
Perfect. So that is his hearing. So next, after we inspect that, we're going to look at the ear, specifically. We're going to look at the exterior portion of the skin of the ear. Is there any obvious redness, drainage, that kind of thing, or any abnormalities? After we inspect each side, we would palpate the pinna and the truncus. We want to assess for any tenderness to these areas. Tenderness is associated with otitis externa or an external ear infection. Do you have any tenderness there? Okay, I'm going to inspect the other side and palpate. Any tenderness? Okay. After we inspect the exterior portion, we're going to inspect the inside of the ear. At this time, I'm going to start looking at the ear canal or the middle ear, and then we'll proceed to the internal ear where we will visualize the tympanic membrane. I'm going to pull it up, the pinna up and back. I'm going to visualize the ear canal. I'm looking at any ceramin, the consistency, the color, the amount, and the thickness. Then I'm looking at the ear canal for any redness, that kind of thing. Then once I visualize the tympanic membrane, I'm looking, is there any bulges, is there any fluid, is there any air bubbles? I'm identifying the landmarks within the tympanic membrane, like the malleus, to help me visualize where I am. And I'll do this bilaterally. Okay. After the ears, we'll proceed to the nose. First, again, I will inspect the exterior nose. Is there obviously any deformities, any deviations to one side or the other? Is there any obvious drainage? After inspection of the external nose, we'll look at the inside. When I look at the inside, I'm looking at the mucosa. I'm going to let him tilt his head back. Look, is there pinkness, turbinates, is the septum deviated, that kind of thing, any obvious drainage or abnormalities. Then after we inspect the nose, we will palpate it. We'll feel in the bone and the cartilage. Is there any obvious deviations? Could they possibly have ever had their nose broken? That kind of thing. So that's what we're looking at the nose. After the nose, we're going to proceed to the mouth. We're going to inspect the external mouth, specifically the lip line, to look, is there any lesions, that kind of thing that could be associated with a disease process or an infection. Then I'm going to ask him to open his mouth. When we look in the mouth, we're going to look at the mucosa, we're looking at the teeth, we're looking at the tongue, we're looking at the palate, and under the tongue, we're visualizing the glands. If you stick out your tongue and say, ah, at that time, I would be inspecting the pharynx. Close your mouth and I'll talk about it. Inspecting the pharynx and looking at the tonsils, any postnasal drip. Also, this time, it would be a good time to check the gag reflex, which is a good part of your cranial nerve assessment. You would use a tongue depressor for that. I don't actually have that today, but you would insert that in the back of the mouth and make sure that they have a good gag reflex. Also, unless you stick out your tongue and put it side to side, up and down, okay? There, I'm just checking the tongue's movement. I'm checking for symmetry. And again, you're always going to look at the tongue as a part of your mouth assessment and throat assessment. Then after inspection, you would also palpate the tongue and the inside of the mouth, especially if there was any abnormalities. Okay? Now after that, we're going to proceed to feeling of his lymph nodes. Well, before we do that, we're going to do his sinuses, and then we'll do his lymph nodes. So we've got the temporal and the maxillary sinuses. I will feel and ask him about any tenderness. I'll feel anything. Then also you would normally percuss. Dullness would indicate increased drainage to those areas. After that, we will go to the lymph nodes. So we have your occipital, posterior auricular, preauricular, parietal, I'll put this in the notes, tonsillar, submandibular, submental, unless you turn your neck to one side. You have your superficial cervical, deep cervical, posterior cervical, and supraclavicular. And you would assess this bilaterally. Just trying to think if I could think of the ones up here, but I'll put that in the comments. So after you do that, then we're going to assess your neck. Certainly with facial hair, that's something I'd have to sit down and do, but you're looking for symmetry of the neck, any obvious bulges related to a goiter or anything like that. Then also we will palpate. After we inspect, we will palpate. You're looking for the is the trachea midline, which is it is. Any obvious bulges is again. Then I'm going to step behind him and assess his thyroid. So what I do there is I'm going to feel his Adam's apple, ask him to swallow, and that will bring up the thyroid so that I can feel it. Will you swallow for me? Perfect. There you're looking for any extra tenderness, enlargement, extra hardness, that kind of thing, which I do not feel. Okay, so after the neck exam, then we're going to proceed to the thorax. So like I said, for the purpose of this video, we are going to maintain some modesty. If I was in a private examination room, I would ask the patient to take off his shirt for the whole exam, but we're just going to kind of improvise throughout this video for modesty. But keep in mind, we'll pretend that his shirt was off at this time. Okay, so I would start in the posterior thorax. Again, you always start with inspection for the most part in exams. Inspection, I'm looking for symmetry. I'm looking for obvious increased work of breathing, intercostal use, any dyspnea that's apparent just by inspection. I'm also looking at the skin at this time for any break in skin integrity, redness, that kind of thing. Jaundice, anything like that. So after you inspect, you proceed to palpation. So for palpation, first I'm going to press on his thorax, ask for any tenderness. Are you tender anywhere? I'm also going to palpate in the costovertebral area to assess for any tenderness there that could be associated with kidneys. Does that hurt? Okay. After you palpate there, you're going to continue with tactile fremitus. So I'm going to place my hands at the side of his posterior thorax and ask you to say 99.
99.
Again.
99.
Again.
99.
Okay. And that's just to check. It would increase if there's increased consolidation in the lungs. So next, I'm going to check his diaphragmatic excursion. So I'm going to place my hands right here and I'll ask you to take a deep breath. Again. Perfect. So that will be palpation. After palpation, and again, we're just pretending like his shirt's off, you would proceed to percussion. I'm going to start at the top, work my way down, and work in a zigzag method per se, just so you can compare them bilaterally. Okay. Then after percussion, you would proceed to auscultation. Now, whenever you auscultate, you're going to auscultate with the diaphragm as well as the bell of the stethoscope. You're going to proceed again in the zigzag method. You're listening for inadventitious breath sounds like crackles, wheezes, or rhonchi. Take a deep breath for me. Okay, I'll let him catch his breath at this time while I get ready to listen again with the bell of the stethoscope. Okay, again. And again, and during this time, in real life, in a real private examination room, the stethoscope always lives directly on the skin. And whenever you're dealing with the skin, you're completing the skin assessment. Okay, after the posterior assessment, we'll go back and we'll do the same similarly on the anterior chest. So again, I'm going to inspect for any obvious increased work of breathing, any abnormalities in the skin. Is there any, and I'll be doing this on the back too, is any bone prominences like scoliosis, kyphosis? Is there any issues with the bones on the front that would show any troubles with breathing? After I inspect, or any increased work of breathing. After I inspect, again, I will palpate, and you're checking for any tenderness at first. Any soreness, tenderness. You're also feeling for any crepitus, which is associated with emphysema. Okay, after palpation there, then we will proceed to percussion. Again, we'll do the zigzag method up and down. In real life, he would not have his shirt on. Here, I want it to be tympanic. I don't want it to be dull. Dull is consolidation. Hyperresonance is air. So after we percuss, we will auscultate. At this time, we're auscultating his lungs. So again, we're going to do it in a zigzag method. We're going to do the diaphragm and the bell. Deep breath. Again. Now making sure I'm listening for a full breath. Okay, after I finish with the diaphragm, I'll move on to the bell. And this will be shortened. You would follow the same pattern. I may give him a little break and just listen in 4 places just so he can catch his breath. Perfect. So that's the end of the respiratory assessment at this time. So from the respiratory assessment, we're going to proceed to the cardiovascular assessment since we're here at that. So before we actually look at the thorax, I would kind of like to step back and look at the peripheral vascular system, which is the part of the cardiovascular system, and then we'll proceed back to the thorax. So with the peripheral vascular, you're going to start with the inspection. That would include looking at the skin color. You know, you're looking for blueness, cyanosis, redness, that kind of thing. You're also looking for any significant edema, any upper or lower extremities, anything like that. From inspection, you're going to move on to palpation. You're going to palpate his skin. You're looking at the temperature, dryness, moisture, that kind of thing. Like I said, throughout this exam, we're doing a skin assessment, but also here we're moving on to peripheral. So especially in the lower extremities, you're looking to see does he have good venous blood flow, that venous blood return, arterial blood flow, that's the reason temperature and skin integrity is important, any thickness, that kind of thing. Now, at this time also, we're going to look at his nails. Now, when you look at the nails, you're looking from an integumentary standpoint as well as a cardiovascular standpoint, or peripheral vascular standpoint. So integumentary-wise, we're looking at the smoothness of the nails. The skin around it, is the nail attached to the nail bed. And then we're looking at the contour of the nail, any clubbing, that kind of thing. Smoothness, that kind of thing. We're looking cat refill. We're going to do this in all 4 extremities. Okay, now, from the peripheral vascular standpoint, then we're going to go back to the thorax and do the heart. No, we're not going to do the pulses. We're not going to do pulses. So that's going to be a part of our peripheral vascular assessment. So palpation, we're going to start up and work our way down. We're going to start with the carotids. Not the carotids, no, the temporals. Carotid. We're going to do this unilaterally. Brachial, radial, femoral, popliteal, dorsalis pedis, and posterior tibialis. And you would do everything bilaterally at the same time, except for the carotids. You would do those one side at a time to promote perfusion to the brain. Now, another pulse that we normally would palpate would be the apical pulse, but we'll do that when we get to the thoracic after that. Then, jugular venous distension, that's something also that we would assess for, and we'll do that when we lay down here in a little bit as a part of your auscultation of your heart. So, cardiovascular thorax, first we're going to start with inspection. We're looking to see, do we see any obvious pulsations, that kind of thing. Again, we're continuing our skin assessment. Inspection, you would normally go on to palpation. Do we feel any tenderness, that kind of thing? Then you would palpate for the apical pulse in his, down under here, and we'll do that in a little bit. So, when he lays back down. So, then we're going to go on to auscultation. And we would not percuss in a cardiovascular assessment just because that's not standard to determine the heart size. Now, whenever you are listening, you're going to listen directly normally on the skin. The shirt would not be here. Then also, we're going to listen with the diaphragm and the bell. We're going to listen to him sitting up and laying down. Start with the diaphragm. Aortic, pulmonic, Erb's point, mitral, tricuspid, and aortic. And again, the aortic is where you would palpate to see if you feel that point of maximal impulse. Then you would repeat that with the bell of the stethoscope, sitting up. Then I'll ask you to please lie down. And we would listen to those heart sounds again with the diaphragm and the bell. And again, this would be with his shirt off, and this would be optimal time to feel for his apical pulse. If I needed to, I could have him turn on his left side. This is also a good time to assess for jugular venous distension, and it's good that the bed is at an angle of 30 degrees because that is optimal. So I'll have you turn your head to one side. Here I'm looking for any extra pulsations, that kind of thing. If I wanted to measure that, I would find where I felt it and it dropped off. I would line that up with a straight edge right here, insert a ruler, and measure that, and that will be jugular venous distension. Okay, and you would do that bilaterally. Now from the cardiovascular thoracic assessment, we'll move on to the abdominal assessment. Now you're going to pull up your shirt for this portion of the assessment. Now the order is kind of different for this part. Normally you go from inspection to palpation and percussion. Here you don't, because that can alter the results of your auscultation. So first we're going to inspect the abdomen. We're looking for symmetry. We're looking for obvious bulges, induration, that kind of thing that could be associated with a hernia, any pulsations, that kind of thing. Then after inspection, again, we're looking at his skin integrity. After that, we're going to do auscultation. I'm going to listen to all 4 quadrants as well as the epigastric region. Epigastric, we're just listening for the abdominal aorta, and that would be with the bell. The rest of it will be with the diaphragm. Okay. After auscultation, we'll proceed to palpation. We'll start with light palpation first, looking for any tenderness, asking him to tell me if he gets tender. Also, you're going to observe your patient's facial expressions to see if they're in any pain. Then again, I don't think I mentioned this, it's always important before an abdominal assessment to make sure your patient has recently emptied their bladder. You're just feeling for masses, asking him about tenderness, that kind of thing. Now from palpation, light palpation, I'm going to move on to deep palpation. It's a little different purpose. It's more to look at the organs internally. You would feel an epigastric region for the aorta. Left upper quadrant, you're looking at like splenic enlargement. Right upper quadrant, you're looking more at the liver enlargement. For that, you can palpate really deep, 2 to 4 centimeters, which is deep palpation. If you can't feel it from there, you can put your left hand under his back, your right hand right here. Ask him to take a deep breath and let it out, and sometimes he'll slide it into your hand. Then if the liver can't be palpated, which is normal, you also could feel for the kidney at that place as well. Then when you think about deep palpation, another thing is rebound tenderness, which is where you deeply palpate on the left lower quadrant. Look for pain on the right lower quadrant, which is associated with appendicitis. After palpation, you would move on to percussion. You would do it in all 4 quadrants. Dullness is associated with the organ. So especially in your upper quadrants here, on the left side you'd be looking for spleen enlargement. Here on the right side you would be looking for your liver. And in fact, you look at the mid-clavicular line, you palpate up until you find the border down, and then that figures your width for your liver. Now, before we proceed, we're also going to do what we call the abdominal reflex. I'm going to step over here and get just kind of a sharp point. You're going to stroke the abdomen. You're looking for the umbilicus to kind of retract, which it has. Okay. Now, also this is a good time to complete the breast exam, which is important for male and female patients. Throughout this exam, it's very important to provide patient education because this is something they should be doing at home. Like I said, for modesty's purposes, we're keeping the shirt on some for you too, but in a normal examination, it's completely confidential. The shirt would certainly be off. You start with inspection. Again, we're looking at skin. Also, we're looking at the breast directly, just looking for symmetry, size, any nipple indentation, any obvious abnormalities, any discharge. After inspections, we're going to move on to palpation. We're going to palpate under the axillary for lymph nodes that are there and any lumps. Then when we palpate the breast, we start in the outer area and circular motion to the inner area. We're going to do that on both sides. So that's the breast exam. Now, from the breast and abdominal exam, we usually would proceed on to the genitourinary exam and the reproductive systems in male and females. For the purpose of this video, we're not going to proceed that actively, but I will describe that in the notes. As a part of the genitourinary exam, we're going to look at the bladder, feel for any tenderness there, suprapubic tenderness. Then when you look at the reproductive system, specifically in the male patient, it would start with inspection. You'd be looking at hair distribution, any obvious skin lesions, any obvious functional abnormalities about the area. You're going to look at the penis as well as the scrotum. If the male patient, has not been circumcised, you would retract the foreskin and look at the urethra and make sure it's in the appropriate location and note otherwise. Also, you would, in addition to the penis, you would palpate the scrotum as well. But we won't do that for the purpose of this video. Then for the female patient, again, it would follow inspection and palpation, and you would use the speculum for the best visualization. Then after the reproductive system, we would proceed to the musculoskeletal system. And we're going to do that we're going to start that before we stand up. So I'm going to let you bend your knees. Go in and out. Back down. Do the same with the other leg. In and out. Perfect. And that's just checking those hip rotations. Okay, so next I'm going to let you sit up on the side of the bed. Or I tell you what, one more time, we're going to check one reflex so you don't have to lay back down. This is called the Babinski. It's part of that neural reflex, and I'm going to say it's a step. So I'm going to slightly do this. I'm looking to see if his toes fan out. That would be a positive, which would not be good. Okay, I'll let you sit up on the side of it. Okay, now we're going to start with the range of motion. I'm going to let you stand up. We're going to start at the top and work our way down. We're going to start with the neck, bend, extend, lateral, rotation. Okay, I'm going to let you do it like a penguin with your arms. Let me feel your shoulders up and down. Okay, and bend them like this, like them. Okay, perfect. And then bend your elbows. Okay, now that's just, I'm feeling for crepitus, didn't feel any. Another thing about crepitus, that's one thing in the palpation of the respiratory system. If we did not address that, it is associated with emphysema. Okay, so range of motion. Okay, elbows, wrists, fingers. Perfect. Okay, fingers. Then next we're going to do the hips. You did that already. Okay, knees bend, ankles. This is our range of motions. You do make your toes. Perfect, 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 perfect. Okay, now that we have completed that, I'm going to let you walk in a straight line for me, and then when you walk back, I'm going to let you do heel to toe walk. Perfect. And next we're going to do the Romberg test. I'm going to let you put your arms out, hold one foot up, close your eyes. Checking to phrase balance, and it is good, so you can open your eyes. Okay, now I'm going to let you sit back down for me. Okay, some more things we're going to work on before we proceed to your neuro assessment, your cranial nerves, which is what we'll end with. We're going to check your reflexes, some of your reflexes. So, first I'm going to let you do this. Good job. Okay, now I'm going to take your finger, and I want you to touch my finger and then back to your nose with your that hand. That'll be perfect. Okay, the other side. Perfect. Okay, now we're going to check your reflexes. Come with your forward. They can't see me that way. Okay. Okay. Then we'll do that bilaterally. I'm going to do your patellar. Okay. Then now we're going to review your cranial nerves and make sure we have all of them. So we did your olfactory. That's your sense. Did we check your? No, I think we didn't do that. So we're going to check your sense of smell. So this is just also checks your nasal patency as well as your olfactory nerve. So I'm going to let you hold one side of your nostril. If you're choosing, I'm going to let you kind of sniff out of the other one so you can smell this.
Yes.
Other side?
Yes.
Good job. Then optic, we kind of covered in your eye exam. We looked at your Snellen chart for your optic, oculomotor, and your third, fourth, and sixth we did with the eye exam. We did your cardinal field of gaze and your corneal light reflex and all that kind of thing. So we did your eyes. Facial is what we need to do next. I'll let you close your eyes and tell me what you feel is soft or painful or sharp.
Sharp. Soft. Sharp. Soft. Sharp.
Perfect. Okay, now, can you raise your eyebrows, let them down, smile, show me your teeth, frown, puff out your cheeks. Good job. So next, another thing we do is check his gag reflex. I think we kind of did that when we were looking at hypnotism because we put the tongue depressor, check his gag reflex. Now, so stick out your tongue, side, up and down. Good job. Now, open your jaw, shrug. I think that's it. One thing I did notice that I didn't do is height and weight in the beginning, as I should have, and that's something that would always be important. I guess you could technically do it at the end of an assessment, but that's an important part. And certainly anything we left out, we'll think about and leave it in the comments, but I think we pretty much covered everything. So thank you very much.